Hey everybody, Dr. Rob Silverman here, Proven Health Alternatives. I've got superstar functional neurology chiropractor, world-renowned Dr. Mike Powell with me. Mike, how are you today?
Doing well. Great to be with you, Dr. Silverman.
I am happy to be here with you. Let's just start right off. We're going to talk about the brain. So my question is, why the brain? What's so important about the brain?
Well, as you and I think probably most of your listeners know, that there's nothing in the body that the brain doesn't have some influence on. And I'm a chiropractor, so certainly when a person has a stroke and their body changes, that's a two-way street. So a person has a stroke and their right arm's kind of spastic and curled up and their right leg doesn't move quite like it should. We know the brain did that, okay? Kind of certainly a pathological example, but we also know it's a two-way street, that when the arm or the leg move differently, signals go back to the brain that have an effect on it. So kind of in just the most basic concept, the brain has a huge effect on the body and vice versa.
So Thomas Edison once said, the chief function of the body is to carry the brain around. For me, the brain is the most nutrient dependent, energy dependent, and toxic and stress vulnerable organ. Adding a little color commentary to it all, the brain is about 75% water, 60% fat. They've got 80 billion neurons on average, 1,000 trillion connections between brain cells and the cortex. Interestingly enough, in these factoids, the brain takes up 20% of blood and oxygen in your body, 25% of glucose. It's 60% white matter, and everybody, your brain feels no pain. With that all being said, little background stuff about your clinic teaching. Why did you get into the brain-based in the first place? I mean, you are an expert. You travel around the US, you speak internationally, you're a super nice guy, you're super humble. Why the brain?
Well, I went to school to get into healthcare and didn't want to keep going to more school and borrow more money. So I used my biology education to get into teaching. So I was a high school teacher and coach right out of college. And during that time, during that 5-year span, my dad had a stroke, and very close with my father. And, you know, as frustrating as it obviously was to him, it's pretty frustrating to me. And he had the things I just described. One side of his body was impaired and partially paralyzed, and was about a year of, you know, inpatient care, outpatient rehab care before he was functional again. Obviously still impaired, but functional again. He was a chiropractor. And so as I was looking at going back to school to get into healthcare, that was a big rock in my shoe to try to, you know, understand, you know, what the heck, what happened with my dad. I'd ask the doctors that were working with him, the staff there, you know, why do you have a stroke? Don't know. Where's it at? Well, it's over here. It's on the left side of the brain. I was like, you know, I'm not a physician, but I know the right side of his body's impaired. You know, I knew it was on the left side of his brain too. And there really wasn't a whole lot more to it than that. And certainly not that I've answered all those questions for everybody, but that really pushed me to really want to understand the brain better and know that I could serve people better. And then, Rob, as you know, at some point, it was when I was in finishing up chiropractic college, I crossed paths with a Dr. Ted Carrick, who's a huge pioneer in the functional neurology field, and was able to kind of hang out in the same room with him as I was working for the postgraduate department, as he would show videos of patients who had been in a coma for 2 years or more in hospital beds, and using things that would fit the chiropractic paradigm, certainly not traditional chiropractic adjustments at all, but things that fit the chiropractic paradigm of use the body to affect the nervous system. And there's video of these people waking up. And so pretty hard for me not to be passionate about that with that background.
Yeah, Dr. Carrick, without question, is a pioneer. He is the founding father of the concept of functional neurology. Functional neurology is as good a diplomate as there is in chiropractic educational postgraduate genre. And it's fascinating to hear you talk about what drove you in, because, I think chiropractors are vastly unique in that there's something that happened in their life, or something that somebody did to them that drove them into their chiropractic or aspect of chiropractic. Now, you said, and you took it for granted, the left side of the brain affects the right side of the body. Could you explain why that happens in the cross circuitry, et cetera?
Sure. I mean, when you, for voluntary movement, not for everything, but for voluntary movement, it's just where the wires go. So the area of the brain that you use when you think, hey, I want to move my arm, it comes from the other side of the brain and goes down, crosses over in the brain stem, and goes down the opposite side of the spinal cord, and then ultimately, after a little daisy chain of neurons, goes out to the muscles that would move that arm or that leg voluntarily. And the same thing is true on the way back in. It's a two-way street. They don't follow exactly the same path on the way back in, but the sensory system from, for example, the right leg, goes in through nerves in that leg into the right side of the spinal cord and crosses over and goes up and through the brainstem and over to the left side of the brain. So those things, the things that are pretty obvious to us, whether you're a physician or a layperson, either way, if you want to move your arm and you can't, there's a pretty good chance that there's a problem in the other side of the brain that's interfering with that signal. And from the same aspect, if that arm doesn't feel right to you, that weird feeling is being perceived in the other side of the brain. There are many brain functions that don't crisscross like that, but they're less obvious and they're a little harder to flesh out, but they're really, really important. But those are the ones that we call kind of classic in terms of neuroanatomy, and that give us some classic neurological signs. And folks with strokes and brain injuries and spinal cord injuries really illustrate those really, really well for us. And I got to tell you, as much as, I learned, in school, and I took coursework from Dr. Carrick and taught for him, and lots of study, those patients that have, these neurological disorders or any disorders, man, they're more valuable to me than any textbook or lecture. I've learned so much from them over the years, and it's just a blessing to be able to take what you learn from, whether it's other patients or from academic study, and apply it with folks and try to help them. And certainly through trial and error, even if it didn't go quite the way you wanted to, then down the road, that may help somebody else. So anyway, that's a long answer to your question, but the brain is generally a crisscross system for voluntary motor and sensory perception.
So, not to get too technical, but you're saying that it goes up my right side, comes up here, and then crosses in the brain up here?
So sensory information goes up, right? So sensory information goes into your spinal cord, and then most of it crosses over to the other side in the spinal cord, and then goes all the way up your spinal cord in your back, up into your brainstem on the side opposite that it came from. So if I pinched you on one leg, that pinch went in through a nerve in that leg, into your spinal cord, had to go through your spine to get into your spinal cord, and then up the opposite side, and then up to the opposite side of the brain, and then you perceived it on the opposite side of the brain. So that's like a pinch or a burn, or it's cold, or it's a tickle, or whatever. There's other sensory information that you're not conscious of. So we're not always conscious of most of the really important stuff. We're not conscious of. We're not conscious of whether we're right or left in gravity. Those little things, we take it for granted. Or the angle of your elbow. If it's 85 degrees or 86 degrees, you don't know the difference of that. Those things are called unconscious proprioception, and they don't bother you the way pain or heat or cold might, or they don't reach perception like that. But boy, are we dependent on them. And they go up the same side of the cord that they came in on. So from the right leg, if my right ankle's tipped a little bit, let's say as I'm stepping off a curb, and my ankle's tipped a little bit and I was at a vulnerable angle, or maybe if I step down wrong, I'm going to sprain that thing. That signal goes zinging in through nerves in my right leg, Okay, this is unconscious. I don't even know what angle my ankle is at. Goes in through those nerves, goes into my spinal cord, and most of it goes up the same side of the spinal cord and to the same side cerebellum, and then it crisscrosses and goes to the other side of the brain. Either way, it gets there. It's just, how you want to get around the barn to make it happen. So
Outstanding. So obviously central nervous system, part of the central nervous system is the brain and the spinal cord. You've done a great job of making this very complex idea extremely digestible. So how does brain function truly intersect with chiropractic? And then, if you will, chiropractic neurology or functional neurology?
sure. So, I think most people's perception of what happens with chiropractic visit is that, irregardless of why one might see a chiropractor, they're probably going to get some kind of treatment. Part of their treatment plan is going to have something to do with mechanically changing their body. That's probably going to be part of it. They may get nutritional recommendations, they may get exercise, they may get all kinds of other things, but certainly it's a bedrock of chiropractic care that the body's mechanics have something to do with health. And Lord knows that, if your hip's not moving quite right and your hip hurts, maybe if we got it moving better, your hip might feel better. That's on the extremely basic side. And conceptually, does that intersect with how the brain works? It does, but really what we know is that example I gave you is, as you go to step off the curb and there's some angle to your foot, if the bones of your foot are not moving properly, or the muscle tone in your foot is something other than optimal, then the signals that are generated by that foot, all these different joints and muscles in your body generate signals that go to your brain, just like we've been talking about. It's like your eyes do, your ears do, your taste buds do. So if those signals that are going off from my foot as I go to step off the curb are less than optimal, then my brain is not going to have an accurate perception of where that foot is. Okay? And if my perception is not accurate, vast majority of this is unconscious. We take it for granted all the time. It's a blessing that we can, but it's a problem when it's not working right. So I go to step off the curb, and if my brain doesn't perceive that ankle right, there's a pretty good chance that as I start to roll that ankle, my brain's not going to pick up on that, and it's going to turn into a sprain, and I'm actually going to roll it and sprain it. On the other hand,
time out.
Sure.
So you're saying, as I understand it, and this is breakthrough for everybody, the ankle sprain is not a ligamentous failure. It could be a neurological failure.
The neurological issue makes the ankle vulnerable. Okay. So if you put me, if you lock my foot up between a couple guys in a basketball game and push me over, there may not be a whole lot I can do about it, and it exceeds the capacity of any ligament, even in a very healthy system. But that's not the way most people sprain their ankle. They sprain them the way, doing normal everyday stuff.
The reason I ask,
it's not working right, the body part's vulnerable.
Right. The reason I ask is the ankle sprain is the most common sports injury, and it has an 80% reoccurrence rate. So as you know so well, a lot of people go and get it treated and not come to a chiropractor who is neurologically based or functionally based. And then we start doing proprioception, the balance in space between your nervous system and your muscular system. And if you believe in root cause resolution, everybody's going to adhere to what you said. I think what you just gave was a clinical gem, that the ligament fails because there's a neurological incorrect impulse.
Right. So yeah, it makes it vulnerable. It's just like if your vision's bad, you're more likely to run into something. You know what I mean? So the signal's not being processed well, it makes you vulnerable. And if, on the other hand, we'll just stick with that ankle, and we make sure that the muscles, the ligaments, the bones, the joints are properly aligned, properly moving, and they're stable, then the signal that comes off of them is going to be more accurate. And when I step off that curb and my ankle's in a vulnerable position, if I've got good signals coming off that ankle and the brain perceives it properly and accurately, then as soon as it starts to tip towards possible injury, my brain's going to say, hey, no, wait a second. That is going to do this unconsciously. It's going to say, that's not right. That doesn't fit the plan we have for that ankle. And the brain will, without your consent, unconscious, really it's a vestibular type of a reaction, will put that back into a stable position. Your foot lands, and it's that day where you said, hey, I almost sprained my ankle today. And then you forget about it versus the day you sprained it and now your foot's in a bucket of ice for 2 weeks. So, Rob, certainly, so we could use adjustments. We could use other techniques to get that ankle, that foot working better. Certainly, if someone suffers an ankle sprain and they don't want to have another one, which, as you pointed out, is extremely common, and we could put that with other injuries as well. You'd certainly want to have a full range of motion, full strength, no swelling, no tenderness, that sort of thing, to be able to say, hey, this person or this athlete is ready to sort of get back in the game, get back to practice, get back to training, whatever. And we know that that's usually what happens, but still it's extremely common to sprain that ankle again. And so what we do and what folks in the functional neurology world do is they'd say, hey, you're not ready for full competition or full training with no restrictions until your brain's right. Your brain has to perceive that ankle properly. And so as you would enter care, not only would we be looking at the ankle, you're looking at your balance and your eye movements in as many ways that we could sort of peek in and understand how various areas of brain circuitry are working, not only to understand maybe in terms of targeting specific care to try to make the brain work better, but also as a pre and post yardstick. So when you want to, it's a little period of time later and you want to start practicing again, we can look at your balance, we can look at your eye movements, and we can look at some other yardsticks of brain function and say, hey, the ankle looks good. That all's clear. And the systems that provide that unconscious proprioception that's so important, not only for function, but to avoid re-injury, hey, they look good too. I think we can stamp you ready to go again. Does that make some sense?
That makes a lot of sense. That I'm hoping that every athletic trainer, physical therapist, chiropractor, personal trainer that works with ankle sprains is realizing that it's not just a question of addressing the ligament, it's addressing the circuitry, the proprioception, if you will, and balance training, things of that nature, so we can decrease or precipitously decrease the amount of recurrent ankle sprains. So now that we got that, I wrote this down. When a patient presents with severe dizziness, seizures, head pain, concussion, traumatic brain injury, or other disabling conditions that has not gotten much better, with lots of diagnostics, care, some treatment over the past few months or years, what's the role of a functional neurologist in that patient?
Sure. So patient has a condition that's changed their life, disabling or somewhat disabling, and they look good. They look good. Their MRI looks good. They don't have brain damage. They don't have an infection. They don't have BPPV, any of those things, which, by the way, is extremely common to have those types of issues and have negative imaging. I mean, that's the most common outcome of imaging when that happens. And it's, by definition, that's the case with a concussion, for example, is that your imaging is negative, or we don't call it a concussion. So basically the role of the functional neurologist is to try to understand what's not working right. So all that other workup was what's damaged. Well, we can't really find what's damaged. There doesn't seem to be anything damaged, but they're still having problems. So the question is, well, what's not working right? Because obviously something's not working right. So we need to look at, is there an issue with brain? In all of those examples you gave, there probably is. It's pretty obvious that there's some neurological consequence there. So brain requires fuel, proper nutrients in the right amounts. So we have to look at breathing. We have to look at blood sugar. We have to look at labs that would give us some clues as to whether, not necessarily if a person is grossly anemic. Certainly that would get in the way of brain function, but somebody probably would have caught that in that workup that you described. Okay? But are they borderline anemic? And if they're borderline anemic, that means that if a system's pushed a little bit hard, maybe what's an adequate fuel supply isn't enough. Okay? And so all of those different metabolic issues, try to flesh those out, because if you don't have that foundation, it's pretty hard to recover from this injury or this onset of whatever the issue was. So that's a big step one. And then step two, we try to understand what circuitry isn't working as well as it could. And I think of it like you're trying to tune a piano, and there's a bunch of mechanisms inside that thing. The lid's down. Not that I'm a piano player or piano tuner, but this is the way I perceive it anyhow. You tap a key, and that sounds pretty good. So whatever that's wired to must be all right. You tap another one, a little sour note. So whatever that's wired to inside, something must not be working right with it. And we can use very, well-established neurological, what we could maybe call bedside testing, to look at variety of eye movements and balance and reflexes and strength and sensory testing. We can do sometimes cognitive testing as well, to get a handle on what area of the brain may not be working as well as it could. And any one test isn't going to answer that for us, but a combination of them, combination of sour notes all associated with a certain circuitry that have something in common, give us a bullseye. And now we've got a couple things. Now we've got something to aim for, okay? An area that is somewhat specific, as if you were doing fitness training or strength. If you were helping someone with strength training, you might want to identify what are the weak or vulnerable muscles and focus on those initially to get them to a certain point, and then you could do a more generalized program. In the same sense, there's definite benefit to trying to identify what circuitry isn't working well, number one. Number two, asking the question, how could I strengthen that circuitry? How could I put traffic as a clinician with that patient? How could I put traffic on that circuitry specific to that one as best as we can, similar to stressing a muscle to try to hypertrophy it? How can we stress that circuitry at a level that the patient can tolerate, but hopefully strengthen it? Okay? And then thirdly, with that testing, we've established, as I mentioned before, some yardsticks to measure to see whether things are really changing or not. Okay? So localize, come up with a plan to stress the area that seems to be vulnerable in a way that they can tolerate. So what's too much, what's too little, we got to find that sweet spot. And then using pre and post testing that was established initially frequently, very, very frequently, to see whether we're moving in the right direction or not. And I just want to add that doesn't work real well if we don't have some baseline established metabolic health. So if their nutrition, if their breathing, if their sleep, if these other things are not as close to optimal as we can get them, and some things everybody needs this optimal, and some things are kind of individualized, then those are tough, especially in the really, really challenging patients, which is a big part of what we do in my clinic.
How vital are high-tech tools for diagnostics in treating neurological problems?
Okay. So they're very vital in identifying, is there damage or not? So that's imaging, that's MRI, that's also electrodiagnostic nerve and muscle testing, extremely valuable there. Most of the patients that come into my clinic, and a huge number of folks walking around pretty frustrated, have conditions that either had negative imaging or their imaging showed they have an issue and that issue is now stable. And it's been years, they're still concerned about the problems that they have. They don't seem to be vulnerable to that problem, to that whatever happened, that damage, let's say, from a brain injury a decade ago or something, but they're trying to get it to change. So going back to that, where is the issue? How might we strengthen the issue? And then very, very frequently, pre and post testing to see if things have changed or not. that really lends itself to low-tech testing because, if someone's in our office, like this afternoon, I'll see someone after we get done visiting that had, for the first time, some brain damage as a teenager, and it's 40 years later. Okay, so so we know the condition is stable, but we also know that it's causing this person a lot of problems, or they wouldn't be showing up to see me with a 4-hour drive and whatnot. Mm-hmm. So with that said, whatever I do in terms of treatment with them, it would be nice to be able to do something and then stick my toe in the water and see if something changed for the better or for the worse. And so low-tech testing, by becoming quite expert at making observations with eye movements, are so useful, and balance and reflexes is really, I think, the best path in helping those that have basically non-emergent, non-inpatient neurological issues, because it's you just need to check them so frequently to sort of find the path to get this thing right. A lot of trial and error. It's hard to trial and error with electrodiagnostics, and doing it 3 or 4 times in one day. And then I'll see you on Wednesday and we'll do it several times again. That's just not practical.
You talk about a lot of low tech, and in that low tech, you've mentioned a couple of times examining the eyes. Could you expand on that? Like, what are you doing? Like saccades, anti-saccades?
Sure.
Why?
Sure. Absolutely. We talked before about these little pathways that go up through a nerve and up the spinal cord, and they wind up somewhere in the brain. So lots of different brain functions require specific circuitry in the brain. So for example, for me to see you, Rob, on the screen here, it comes in through the eyes and it winds up perceived in the back of my head. That's where I see you. And we know that some aspects of that are, like your position in the room with me is perceived more so up towards my parietal lobe, and other things like some of the contrast and whatnot are perceived more in my temporal lobe. So there's different areas of brain that are assigned to different brain functions, and there's lots of sharing between these things. Okay, so we know that an area towards the front of the brain up here, if I'm going to glance from one side to the other quickly, that area has to work properly. And so if I put a target in front of somebody's face and I quickly move it from one side to the other, and there's a delay, let's say the target moves and then their eyes move. We go the other way, it's fine. Everybody else I look at, it's fine. But when I go from here to here, their eyes have a little delay and then they catch up. We would know that it's very likely there's an issue here. So an issue, does that mean there's brain damage there? Well, if a person has brain damage there, certainly they probably will have a problem with that fast eye movement, but that's not the case with most people. Most people have an area that's not working well, even though it's anatomically intact. And then we look at other functions or other ways of testing that neighborhood or that area. And if several issues show up, then we start to get the picture that, you know what, this all looks pretty good, but this area here, maybe in a certain area in the frontal lobe, doesn't seem to be working that well. And then we can come up with therapies to try to target that area. And in the same way, we can use slow eye movements. We can use convergence eye movements to identify if a certain area of the brain doesn't seem to be working right. And just like I mentioned before, any one test isn't real reliable. Some tests are more reliable than others, and the eye movement tests are fantastic for this. But by itself, it's not that reliable. But then we start piecing together a little more evidence and a little more evidence and a little more evidence. You start to put a picture together. You have some measurements, some data that you've collected, and then neurons. You mentioned a bunch of things that are impressive about the brain. About what it does and about how much fuel it uses. The other thing that is incredibly impressive and that we leverage in a beautiful way is that it's dynamic and it's changeable, much, much more changeable than your heart or your lungs or other tissues in your body that are absolutely vital, but it's dynamic. So our conversation right here is causing neurons not just to fire to process what we're talking about, but they also change. That experience changes them. Now, if I don't say anything profound, I imagine that you will at some point here, and you probably have already. But if I don't say anything profound, then maybe those connections go back the same way they were before, someone takes in this our talk today. But if something sort of sticks with you, then those neurons are physically changed. There's physically connections that formed. And so that's what the therapies try to do. The therapies that we might use would try to increase connections in a certain area of the brain, and then we can do some post-testing to see if it really happened. And eye movements are just really useful windows into various circuitry.
Wow, there's a lot to unpack there. So that rewiring you were talking about, I think the term that you wanted to tell everybody, and we're going to go into the rabbit hole in this, is neuroplasticity, the ability of your brain to make new connections. So your brain is able to heal, whereas there's some other parts of area that doesn't heal as correctly. So neuroplasticity is based on the increase in the release of BDNF. And I'm going to seed the conversation by saying that BDNF is a protein enzyme that comes from your gut. It is the fertilizer for neuroplasticity to your brain, which opens us up to this whole concept of the gut to brain axis and the brain to gut axis, which is, to me, the superhighway to health is bidirectionality. Whatever you do to your gut, you do to your brain. Whatever you do to your brain, you do to your gut. Whatever you do to your brain or gut, in a millisecond, it communicates with the others. So it's a fascinating intersection, which I believe may highlight a good aspect of where functional neurology and functional medicine meets. Now that we covered all that, what I found fascinating, it just came across, I actually saw Andrew Huberman talk about it, and he spoke about actually weight resistance exercise, where your brain is actually releasing and stimulating a conversation with your bones. And people don't think of the bone as an endocrine organ, but your bone releases calcium, and that calcium can actually stimulate neuroplasticity. So I didn't tee up one ball for you on a golf course, if you will. I think I just teed up 3 or 4. So come on in and add some color commentary to that.
All right. So when I mentioned before about the stress the area of the brain to try to make it work better and create that neuroplasticity is a beautiful concept. But once again, it doesn't work very well if you're not healthy. In a basic sense, if you're not healthy, it doesn't work very well. Or if something in your metabolism, in your physiology is roadblocking that, it doesn't work very well. And so certainly optimizing that is huge. And one of those things to try to get more of those connections to form is to set the stage for more nerve growth factors like BDNF, like Miracle-Gro for neurons. And so we would like that to be in abundance when we go through that process of trying to stress neurons through various exercises and activities to make them work so that they're more likely to grow more branches, just like Miracle-Gro makes the plant grow more roots, more twigs, more leaves. The same is true of the brain chemistry that we're talking about. So if the gut's not healthy, that's a pretty big roadblock to recovery. One of the things I find is that oftentimes I'll see people that have not done well with lots and lots of different types of care for maybe a long time. And that if we can get the stage set for a healthy brain, gut, glucose metabolism, maybe toxin clearance, those physiological foundations of health that everyone needs, and they may need specific intervention for that particular person. If we can get that there, and then take whatever circuitry is not working well and push that a bit, and then we have some evidence through eyes, balance, maybe their labs as well, that things are working better, then a lot of times the stuff that they did before starts working. The classic example that I wind up with in my office periodically, and it's just fascinating to me how well this works, is there'll be a child that starts speech therapy at, like, let's say age 4, and they make some gains, but they plateau. And now it's age 6, let's say. They've plateaued, and the things that tend to work to get that child to the next level of whatever the speech issue is just aren't coming around. and hasn't for a while. They haven't hit their current goals, so they're released from care. Well, some of the speech therapists will then send them to us, and I'll do what we've been talking about. I'll do my best to try to set up a situation where they have as healthy a physiology as possible. Young kid, that's usually not real hard. So that's great. Try to understand what areas of the brain aren't working as well as they could, try to make those stronger. And then even though their speech may not be any different than the day they stepped into our clinic, let's say 3 months prior or whatever it is, if their eyes are moving properly, if their balance is looking good, the reflexes are the way they should be, if whatever measurements of lab testing look like they're lined up well, then I send them back to speech therapy, and speech, the same things that they were doing before start working. And Rob, the way I think of it is that I obviously think of a lot of simple analogies as I'm sharing them, but the way I think of it is you've got this chest of tools. This kid's got this chest of tools, and there's drawers with all these tools in them, and they can make wonderful things with them, but one of the drawers is locked. And so they can make stuff, but they can't make it as well as what their maximum potential is. They can make a thing, but maybe it's not art. But if we could just unlock that drawer and give them an opportunity to use that part of the brain or the tools in that drawer, then things start to work well for them. That's where I see the role of setting the stage for proper nerve growth factors, and then doing the things that take advantage of that fertile ground for connections.
Outstanding. So let's give some examples. We've talked about the brain, we've talked about the gut. Let's talk a little bit about, we mentioned TBI, let's call it concussion, TBI, whatever your comfort is in the parlance. So what would you be looking for in concussion? And I'll fill some color commentary in with you now.
Sure. So, and we've intersected on this topic a little bit in the past. So certainly with concussion, I don't see people on the sideline setting very often. I mostly see people concussion, whiplash. There's lots of overlap there. And now it's 3 months, 6 months, a year later, and they still have daily headache, and they walk in the grocery store and they get dizzy and they have symptoms. So that I find that particularly in that population, it's even more important to get that physiology foundation set first before we stress the brain, because the brain's not tolerating stress at all. That's pretty obvious. So that physiological foundation, establishing good or reestablishing good sleep with that. And then when they're able to, we start with kind of very low grade exercises based on how they may localize. So they may be doing an eye movement exercise where they do 2 repetitions and wait 30 seconds, and do 2 more repetitions and wait 30 seconds. Whatever the right amount of weight on the bar is for them at that stage, that's where we start them versus some protocol. And Rob, let me give you one more piece particular to the post-concussion scenario. And this has been really beneficial to my patients the last 4 or 5 years where I wasn't incorporating this. And that is getting a specific aerobic exercise prescription into that plan early on, where we do some testing with heart rate monitoring and get a specific heart rate to have them work at for 20 minutes on a stationary exercise bike, which I think is the best way for them to get aerobic exercise. And then we grow that. And my belief is, and I don't know where the research is at on this, but my belief is the reason that is key is because it provokes nerve growth factors. There's probably other reasons as well, but my belief is that aerobic exercise, we know it provokes nerve growth factors, but my belief is that it increases the success rate in those patients because of that.
To speak to what you're talking about, the aerobic, it's the steady state, like you indicated, whereas you're not moving your head or jumping up in the air because that'll bring the symptomology.
Yes.
In that steady state, right? Can you imagine? That
yes, head still in space.
Right. Stimulate. That's why swimming's out, overhead lifts are out, jumping's out. That steady state does stimulate BDNF, brain-derived neurotrophic factors, substantially versus other exercise means without the side effects. For me, one of the big ads, and like you said, we've intersected on this in a very positive light, is a nutritional protocol to feed the concussion, if you will. The first thing that I recommend, and we'll go into more detail in a moment, is ketogenic diet, which is about 75% fat, 20% protein, 5% carbohydrates. Fat is clean fuel for the brain. Carbohydrates are dirty fuel, everybody. Fat is clean fuel. When you're able to get into ketosis, you're now producing ketone bodies, which are a great energy source for the brain. Some other things that I recommend is creatine. Creatine typically gives the brain an intense immediate energy to heal cells. It's great for short and long-term amnesia. You also want to reduce the inflammatory state in the brain. So you want to decrease it. Turmeric, ginger, boswellia, quercetin, they're great hacks. But the big one is the EPA, DHA, omega-3 fatty acids. Data has shown that if you want to decrease brain tissue damage post-concussion, one of the best choices would be omega-3 fatty acids. And the caveat is to take it before the concussion. So all those people who are dealing with high school, college athletes, omega-3 fatty acids is a prescription choice. Antioxidants like alpha-lipoic acid, a great ad. And for me, the gold medal winner, pro-resolving mediators. They allow for the resolution of inflammation. And I would be amiss if I forgot to recommend to everybody to take choline. It's critical for brain development, and it switches the microglials from an M1 to an M2. So they go from a pro-inflammatory state to an anti-inflammatory state.
I love it. I agree with all that and incorporate much of that. It's interesting. We know that the number one reason that a person who suffers a concussion still has issues 2 weeks, 6 weeks, a year down the road is because they had particular vulnerabilities at the time of their concussion, not because their head got hit harder or their neck snapped more when it happened, but because they were vulnerable before the concussion happened. So your advice about those essential fatty acids and really, optimizing health as an athlete, as anybody who's going to put themselves and their head at risk is absolutely key to making it so if that concussion happens, hopefully it resolves pretty quickly in you.
Without question, I think it's one of the more overlooked things. I mean, I'm going to say it. There's still people that adhere to the idea of rest a concussion, wait, and that's going to be fine. And that's point number one. Point number two, when it comes to a concussion, the myelin sheath is loosened. So it takes a period of time, typically 2 weeks or longer. So that idea that they're going to go to Dr. Powell or Rob and come in on Tuesday and I'm signing Thursday for them to play Friday Night Lights probably isn't happening. So I'd like you to speak to the idea of that myelin sheath and that neurological damage and what's going on inside the brain in a concussion.
Sure. So we know that conventional imaging doesn't pick up on anything when there's a concussion. It's MRI. So the brain looks good on MRI, and by definition, that says you have a concussion. But we also know that on the microscopic level, that things change, and that certainly conventional imaging just isn't sensitive enough. And who knows? Decade from now, maybe imaging will be more sensitive and be able to pick up on that. But when the myelin sheath is disrupted, nerve firing slows. So for a signal to get from point A to point B, there's like a miles per hour, meters per second. There's a speed that has to happen. And and the receiving end, whether it's vision, a thought process, a balance process, whatever it is, when your sensory system picks up on some change and sends it zinging into your brain or through your brain, makes a little handoff to your motor system and says, hey, you need to do something about this. You're almost about to lose your balance or whatever it is. That the faster that signal gets through, the better chance that handoff is going to be effective, and whatever needs to happen, the response is going to happen, is going to occur. The slower that is, the more likely that signal sort of peters out and doesn't add up to enough excitement at that little interchange. And now the thing that needed to happen may not happen, or it may happen with a delay. Myelin speeds up the signaling down an axon of a neuron. And so when the myelin sheath is interrupted in any way, whatever that might be, then that signal is going to be slowed, and the response is going to be sluggish at best, maybe absent. So that system needs to be intact.
And we know that the myelin sheath is helped by the consumption of omega-3 fatty acids, whether they're supplemental or diet. And the myelin sheath, we want to differentiate damage to the myelin sheath and concussion versus, let's say, multiple sclerosis.
Right. It's a matter of cause and degree. And we know that, myelin shows up as what we call myelin. Myelin makes white matter white. And so it has a shading that you can see on MRI. And with MS, for example, that white matter is damaged due to an autoimmune process in various multiple places in the brain. And when it's damaged enough, then you can see it on MRI. Probably the first little damage that happens, your MRI would look just fine. It has to hit like a critical mass so that enough of it is damaged that the machine can pick up on it. And in concussion, we think that it probably happens in lots and lots of areas of the brain, and the damage is certainly on the microscopic level. And also the damage is much more reversible and repairable if the proper nutrients are available and proper signaling is occurring, and we make sure that we're not putting the brain in a bad situation while it's still vulnerable to re-injury.
You kind of close up the loop. We kind of went into the rabbit hole concussion. It's still a hot topic. It's a pertinent topic. What kind of treatments would you incorporate with your post-concussion patients?
So certainly some of the nutritional protocols that you mentioned, and then based on their labs, they may have something specific, individualized to them. A huge part early on is this, we use the Buffalo concussion bike test. University of Buffalo is where it comes from. It's available. You can look that up, Buffalo concussion bike test. The lead doctor there that his group has pioneered this, his last name is Leddy, Leddy. So the information from that we use to set the aerobic exercise prescription, and that works really, really well early on. Along with that, we address sleep early on because it's almost always an issue. And so we could spend the next couple hours talking about rebuilding the proper components to get good sleep, not just so you feel rested, but so your brain can repair. And then, depending on what we see with that person, we'll do a series of usually asymmetrical eye movement exercises, head movement exercises, balance exercises. Rob, it's all depending upon what circuitry that individual has an issue with. So if they have a right frontal issue, okay, and we feel like I've established that foundation for some basic metabolic health, that they can tolerate some things. If they have a right frontal issue, I might have them tracking a target from their left to their right, and then having their eyes jump back to another target. So remember, we talked about one of the ways to see what's going on in the brain is we do these diagnostics with the eyes, and that if your eyes don't jump properly from right to left, there may be a right frontal issue. Well, it's beautiful because we can use the test as a therapy. And so we may do that repetitively for sets and reps, do it in the clinic, maybe measure heart rate while we're doing that, or have some other measures to see what's the sweet spot where we can stress this, but not not overstress it, and then work that in the clinic and then send them home with that. With those, we almost always the set of exercises that we get a person doing that are individualized, we pretty much always start that set with breathing exercise. And then we do a breathing exercise at maybe halfway through them, and again at the end, in an effort to both increase oxygen, fuel supply, and decrease. So a really long exhale breathing exercise is what I most typically use. Decrease carbon dioxide. When you accumulate and retain carbon dioxide within you, it sets your body off into a more sympathetic fight or flight type mode. That's something that we probably don't want. I'm going to add one more little piece here as I'm thinking about this with what you mentioned earlier. with the ketogenic diet, which I really, really like. One of the things that people oftentimes do with the ketogenic diet that I really like, but not in these fragile post-concussion patients, is fasting. And so they're quite vulnerable. And so we try to limit the stressor to the areas of the circuitry of the brain that we want to make stronger. And we try to keep the other stressors minimal. And so it's pretty stressful not to eat for 14 hours. Okay. And it's fine. I think it's, for you and me, probably a good thing to do. But when you haven't recovered from your concussion and it's 9 months later, then I do have them use a ketogenic or similar diet, but I do have them eat a small portion every 2 hours. And this is from lots of trial and error. And I found that, hey, let's have them fast and maybe that'll help them clear toxins. Good concept. Most of them can't handle that in my clinical experience. So I think I kind of diverge from some other physicians with that mindset, but that's been useful for me, is to have, get them on a nutrient-rich keto diet, but have them eat every 2 hours, get a good night's sleep, get that aerobic exercise, and specific brain rehab.
I agree with you. The synergy between intermittent fasting and ketogenic diet is well documented. However, the reason that you said what you said correctly is that intermittent fasting produces something called hormesis, a strain to the body. And if your brain is concussed and it hasn't responded, that hormesis is going to be extremely detrimental. So in a great setting, like for you and I right now, who don't have any brain damage that's apparent, certainly not you, it's conceivable with me, you would want to do a ketogenic diet. You would want to do intermittent fasting, because that intermittent fasting would also reset your circadian rhythm, enable you to make BDNF better. One of the things that I like to utilize, and I add in my concussion protocol, is low-level laser. And I want to be specific. I use a low-level laser class 2, a non-heating laser. I use wavelengths of 635, which is a red light, 520 green light, 405 violet light. The studies are robust on helping the brain heal post-concussion, in that they've shown to decrease brain edema, increase angiogenesis, allow new blood vessels to grow, increase lymphatic drainage, increase blood flow and cerebral oxygenation, increase brain-derived neurotrophic factors, increase anti-apoptosis. It stops cell death and also decreases neuronal excitotoxicity. So it's creating an anti-inflammatory effect in the brain while healing it. For me, nothing in the genre of helping a concussion heal I've seen to be more effective than non-thermal low-level laser.
Rob, I just want to comment on what you said, because I love that, you said laser, but then you said why. And I think a paradigm that needs to become dominant in healthcare is, what's not working right? What's not working right in this person, and what needs to change? And then the treatment should be aimed at changing that, versus the treatment for concussion, versus the treatment for MS, versus the Parkinson's protocol. What needs to change? How could we change it? How could we measure it? What makes sense? So, and I think that's what you just said.
I think we together, again, we were talking about this, how we're able to elucidate specific information so doctors and consumers, patients alike, can get some value from our conversation. That's the whole point of the podcast. But all that being put together, I know you're really busy. I was able to get you for 45 minutes, and I appreciate your time. I appreciate your knowledge. And by the way, I appreciate you being such a good man. Anytime I have a question and anytime I see you, you have the time to shake my hand and share a pearl. And I just want to say I appreciate you. And thanks for coming on. We have to have you again. We didn't even get to neurodegenerative disease, so we got to do that next time.
Yeah, that's very kind, Rob. And I had a good time. And gosh, I hope the folks that listen and view the podcast are able to get some things to help themselves and help other people as well.
How can people get in touch with you before we close?
I've got a clinic in Cedar Rapids, Iowa, Powell Chiropractic Clinic, and you can just dial that up on the net, and you'll be able to find some links and things there. So
Well, there you go. I love the pictures in the background. It's been my pleasure. Dr. Mike Powell, Dr. Rob Silverman, Proven Health Alternatives, always yours in health.
Thank you.